Treatment of an artificial lateral clavicle fracture by Professor Dr. Rainer Meffert, Würzburg, Germany. Fracture classification. This case shows an artificial type 3B1 displaced extra-articular fracture on a specimen. Confirmation of the diagnosis was made by X-ray and CT scan. Surgical approach and fracture preparation. A superior transverse approach has been chosen. The skin and soft tissues are divided to expose the fracture. During dissection and cleaning of the fracture gap, a lateral clavicle fragment is seen to be displaced superiorly. The lateral fragment is shifted medially, partially overlapping the medial fragment. Meticulous cleaning of the fracture gap is necessary for accurate reduction. Plate selection. Select the appropriate clavicle plate from the portfolio. For superior plate application, there is a selection of plates available. There are superior midshaft plates, superior lateral shaft plates that are designed to be positioned between the midshaft and the lateral end of the clavicle, and superior lateral plates available. For this particular case, a superior lateral plate is the most suitable option. Preparation of the coracoid and suture placement. For fractures with CC ligament disruptions, the plate can be equipped with a suture button insert. This will reduce the clavicle back into its anatomical position. The coracoid is palpated and soft tissues are being further opened towards the anterior aspect of the clavicle by creating a pocket through which the suture can be threaded. Utilizing a bent, pointed flat-nosed pair of pliers, the suture is held in a loop and is maneuvered around the coracoid from lateral to medial and retrieved on the other side. The secure position is checked by applying a tensile load on the suture. Plate positioning and fracture reduction. Mark the lateral margin of the clavicle with a K-wire and position the plate over the fracture, respecting the position of the K-wire. For temporary plate fixation, double-pointed reduction forceps can be used in the dimples between the plate holes. Additional olive K-wires secure the position. The central position of the plate on the clavicle is palpated, making sure the plate fits the bone. The anterior flap should be in contact with the bone surface and can be placed under the deltoid fascia. For easy and guided positioning of the lateral screws, a drill guide block can be attached to the lateral aspect of the plate. The integrated screw in the drill guide block is finger tightened until there is no play between the plate and the drill guide block. For additional temporary plate fixation, olive K-wires may be used through the drill guide block to secure the lateral fragment. The flaps are in direct contact with the lateral anterior aspect. Fixation of the plate. With the drill guide, the first core hole is drilled in the clavicle shaft. If screws are used bicortically, a broad bone elevator can be placed under the clavicle while drilling, as this may prevent overpenetration of the second cortex. The screw length is assigned using the depth gauge and the appropriate screw is chosen. In this case, a golden cortical screw is inserted. Now the lateral screws can be placed by drilling core holes by means of the drill guide through the drill guide block. Here, tri-lock screws are used for increased stability and the creation of a fixed angle construct with diverging screws. As every screw gets inserted under an individual angle, the stripping stability of the lateral construct is increased. Further tri-lock screws are placed in the shaft of the clavicle in order to increase the overall stability. Care should be taken when placing the screws bicortically in order not to protrude the inferior cortex. After removal of the drill guide block, tri-lock screws can also be placed through the anterior flaps. Caution should be taken not to collide with the superior locking screws. Retrieving the suture. To retrieve the suture from underneath the clavicle, the flexible suture retriever is used. The suture retriever is inserted into the guide through a pre-drilled hole, and its handle is turned until the curved tip of the instrument points towards anterior. Both suture ends are threaded through the loop of the suture retriever. By pulling the suture retriever up, the suture ends are passed through the clavicle. The suture ends can now be removed from the suture retriever. The insert for suture fixation is held with the labeled top on the handle. The suture strands are passed through the insert, making sure the suture doesn't get twisted. Tightening the sutures gently, the handle can be snapped off. The suture is pulled to get the appropriate tension and reduction and is secured with a double surgeon's knot over the bar. Postoperative X-ray. Good reduction was achieved with the anterior screws crossing the superior screws laterally for increased stability.